in the response to carbidopa-levodopa over time with the disease. So it will work well in the beginning in most cases, and then as the disease progresses, you kind of tend to have more fluctuations and ups and downs, like a roller coaster feeling during the day with the dosing that we have. So trying to add in different medications like ristagyline or dopamine agonist can help with that, but it can get to a point where there's just hard to stay in this sweet spot of therapy where you feel good without having dyskinesias and without having your off symptoms. So this window of feeling good gets narrowed over time, and so we try to intervene before there's too many ups and downs with your pills alone. And other things to think about, so your the caveat to a good response to carbidopa-levodopa is that sometimes there's things like tremor or dystonia that don't respond as well to the medications that DBS can still treat quite well. So we take that into consideration when we're talking about how you might be a good candidate and what benefit you might get. Usually the first several years of the disease, so in 4 to 5 years into the disease, you're going to still be getting good benefit from those different medication options and other therapies like physical therapy, exercise. And so it's more in that 5 to 10 or later disease duration range that we start considering DBS more commonly. So there was a time going back probably at least several years now that we were waiting until more advanced stages to intervene with deep brain stimulation, and then in the past 5 or so years that has moved to more moderate or mid-stage disease. And one of the big trials that came out that started this kind of shift in timing is the early STIM trial. So this looked at it intervening at a disease duration of 7.5 years. They were all patients on the younger side, so a little bit underrepresentative of our typical population, but still significant findings showing that in the DBS plus medication group, there was a 26% improvement on a rating scale that assesses your quality of life. And in the medication only group, there was a drop by 1% in a 2-year follow-up. So that's a big difference there. And then looking at the motor score, so the UPDRS is a rating scale that we use to look at your movements like finger tapping and toe tapping and muscle stiffness. And in the DBS group, there was a 53% improvement in those scores and a 16-point difference at 2 years. So the DBS plus medication group was doing significantly better. So when we're talking about, again, what factors we look at when we're thinking about DBS, it's a lot of motor symptom response that we consider. There is some research looking at what non-motor symptoms DBS might also help with, but it's not as well defined right now. So the symptoms that usually respond well are the tremor. Bradykinesia is that muscle stiffness, and then rigidity, or bradykinesia is the muscle slowness, and then rigidity is that muscle stiffness that you can have and that we talk about. And usually the UPDRS, that's that rating score again, those scores can improve by 40 to 60% after DBS. And the dyskinesias, that's the wiggly type of movements that you can get from side effects from your medication. So that can reduce by about 60 to 80%. So that's a big deal in quality of life improvement. And then reduced off time. So off time is when you have return of your Parkinson symptoms. So more tremor, more stiffness and slowness. And so reduction in those times in that medication off time has been about 60%. Usually we can reduce medications by at least 30 to 40%. There often we need medications to some extent, but we try to reduce the dose if we can. And it's rare that we would be able to come off all medications. Symptoms that generally don't respond that are important to acknowledge if these are more of your bothersome symptoms. There's postural instability, so this is balance problems outside of having shuffling feet or walking difficulty. If you just have trouble staying upright, then DBS typically does not treat that very well. Speech difficulties often don't respond well to DBS. And then, as I was saying, a lot of those non-motor symptoms that I mentioned in the beginning would not clearly respond well to DBS. But we do see a lot of things like sleep improvement and things like that because your motor symptoms are better controlled. And then if you have some cognitive issues or cognitive impairment, then we would not expect that to get better with DBS. So when we're talking about things that would make you not a good candidate for DBS, we're looking at dementia as a possible contraindication. So we do screening for that with neuropsychologic testing. That's a cognitive test that we do as part of our workup. And then if you have atypical Parkinsonism, so that would be diseases called progressive supranuclear palsy or PSP, multiple system atrophy, or dementia with Lewy bodies, then you would not respond well to DBS. Other things to consider would be if there is psychiatric disorders or diagnoses that might impact your ability to succeed with DBS. We take that into consideration. If we do an assessment and even in your best on state, so as the levodopa is working and you're feeling your best, if you still have significant disability and problems functioning, a lot of it's related to non-motor symptoms in that case, then we would think that you might not get a good response to DBS in those cases. And again, if your symptoms are not relieved, like your most bothersome symptoms are not relieved by levodopa, then you might not be a good candidate, with the caveat that if it's tremor that's refractory, sometimes we can still treat with DBS well. If we do an MRI and there's a lot of changes in the brain that might increase your risk of complications from the surgery, that would be a big consideration that we would talk about. If you have a lot of other medical problems, comorbidities we call those, that would increase your risk of surgery, that we would take into consideration as well. And then a lot of people ask if there's an age limit, which there's not a clear cutoff. We certainly, if you're over 75, would be more cautious about moving towards surgery. We do have a couple patients in their 80s that had successful surgery with good results, though. So in the workup, what we would do is something called on-off testing. So this is that rating scale that I was talking about, where you would see a physical therapist and they would do a videoed scale. So you do finger tapping, you do toe tapping, and they would assess your muscle tone, look at your walking. And you do this first off your medication. So you come in off all your carbidopa, levodopa, or other medications. And then you take your dose and wait till you feel like it's kicked in. That usually takes a half hour to an hour. And then that rating scale is repeated. And we like to see at least a 30% improvement in the scores on that test. Then the other thing we do is the neuropsychological assessment. So I mentioned that earlier. This is a good screening tool to see where you're at from a cognitive standpoint and make sure there's nothing that we need to think about or consider as far as your risks of getting surgery and your ability to kind of understand the risks and consent for surgery, as well as any psychiatric difficulties you might be having that we should address. If you haven't had a recent MRI of your brain, we also would want to do an updated one. So then after these tests are done, we have a meeting. So it's called our DBS consensus meeting. This is with myself, Dr. Nelson, the neurosurgeon, neuropsychologist and physical therapist, and then the care coordinator, who's Kelly Melhorn. So we would talk about the testing and the goals of surgery for each patient and what kind of device and lead placement we'd be looking at for that patient, and then try to make a decision about whether they're a good candidate. So I'm going to mention briefly essential tremor because some of the considerations are a little bit different as far as disease management, and then we talk about programming things afterwards. So for essential tremor, this is also considered a progressive disease. It's usually more tremor predominant rather than so all the other motor symptoms that go along with Parkinson's, as well as the non-motor symptoms. So it's usually just more tremor that we're dealing with, but it can be a very disabling tremor that makes it hard to do a lot of activities of your daily living. So this is eating, drinking, writing. If you have hobbies that you enjoy that involve fine motor things, this can impact things. People that are trying to work in trades or things that require use of your hands a lot and dexterity, this can impact things quite a bit. So it often runs in families. So we tend to see people will say, oh, my dad or mom had it, or my brother or sister. So it does seem to have more prevalence among families than Parkinson's disease. So when we're trying to think about management for tremor, there's different options that we can consider. You're looking at adaptive strategies. So there's things like weighted utensils or different pens, different spoons that might be able to help you adapt. There's a good website, essentialtremor.org, that has a lot of good coping strategies and informations for this. For medications, you're looking at there's not necessarily a huge list or a lot of options. So primidone and propranolol are our first go-to options, and depending on what other medical problems you have, you may or may not be a candidate to try these medications. And then there's topiramate, zonisamide, gabapentin, things like clonazepam or alprazolam are more second-line options and can be effective, but there's also always side effects to consider. And then other treatment options, you're looking at something called MRI, guided focused ultrasound. So this is also interventional, so it's still risky as far as some potential injury to the brain or persistent side effects that happen from that procedure, but you're not left with implanted wires or batteries. But it's not like it's kind of a one and done type of procedure. So deep brain stimulation has still been around longer, and there's more patient volume showing the benefits of DBS for essential tremor. So for this, who's a candidate? This would be if there's persistent tremor, despite trying all the medication and coping strategies and adaptive strategies that we can think of. And this I try to counsel people. So if you get to a point where you can't imagine living with your tremor anymore, then you're probably at a stage where you need to take that next step of getting DBS, because it is obviously an additional risk that you're taking, but it can get to a point with the effect of your tremor and how disabling it is that it's often worth that risk of taking something that has some additional risk to it, but has a huge upside of being life-changing and getting you back to doing a lot of the things that you're struggling with right now. Similar contraindications to DBS for Parkinson's that we would consider with dementia. So neuropsychologic testing is still part of the workup for essential tremor. We don't do the on-off testing because there's not that kind of response to levodopa that we have to assess for essential tremor. And then we would look at your age and other risk factors for surgery as well. Here's an example of a spiral. So if you have essential tremor, you may be used to doing the spiral in the clinic. And so this is an example of the baseline of a patient of ours spiral, and then the after treatment spiral that they were able to do. So here's kind of a flow chart of how it works with where you start and then how to move through some of this workup, where you might start with your primary doctor or a non-movement disorder neurologist and then get referred to someone like myself who is a movement disorder specialist and is involved in deep brain stimulation. So that would be the first step. And we talk in clinic a lot about what you've tried and where you're at with surgery, and seeing me isn't necessarily like now you're going to get launched into automatic surgery. So I try to talk a lot about individual risk and benefits and where people are at with surgery. If it seems like you're at a point where you are a good candidate and we should move forward with testing, then we'll go ahead and schedule that and then meet as a team. Then you would see Dr. Nelson in the clinic for a consult. And if everything's still a go-ahead, have surgery, and then you would see me again for your programming appointment. That's usually done about 1 month after brain surgery, just to let everything heal. And then there's the initial programming visit that would be the month after surgery. And then within those next few months, there's usually about 2 to 4 visits between there. So I try to see people about once a month in the first few times to make adjustments, sometimes sooner. So I'll make a change and I'll get a call saying, oh, this isn't working for me. So then we try to do a sooner appointment if needed. And then it takes, 6 months to sometimes try to get medications and the programming more settled. And then after that, the visits can space out more. Common questions that we get is how long does it work for, which isn't necessarily clearly defined. We do have studies that show at least 5 years of benefit. And then we know from following patients for longer than that they can still have sustained benefit after that. We just don't have the large trials to prove that at this point. Will you be able to stop your medication? So as I mentioned before, in Parkinson's, in most cases, we are not able to stop the medications completely, but we can certainly reduce them in a lot of cases. Sometimes we end up leaving the medications at the same dose, but you don't have the same fluctuations and dyskinesias and side effects that you would get without DBS and the combination. In essential tremor, we can often taper off the tremor medications that you're on, so that's a big advantage there. One common misconception that we hear is that if you don't have tremor, then you're not a good candidate for DBS, and so that would be more, obviously if you have essential tremor, then you have tremor and you would get surgery for that. But if you have Parkinson's, there's 30% of people with Parkinson's that don't have any tremor, and you would still potentially be a good candidate because it can help that stiffness and bradykinesia, the slowness of movement, dystonia, other symptoms of Parkinson's that also can affect your quality of life. And lastly, here is our multidisciplinary team. So Kyle Nelson, the neurosurgeon, so he'll go through his talk next. And he's just amazing to work with, great surgeon. And so without all these people, we certainly wouldn't have the program that we do. And so it's been just really great to work with this team of people, and it only gets better as we kind of solidify our team. So we have DBS coordinators that are involved with Kelly Melhorn and Anushka, and Courage Kenny is highly involved with our on-off testing and then doing big and loud therapy, either leading up to surgery or afterwards. And neuropsychologists at Noran are all wonderful and great to work with. So with that, I will pass it back to Anushka or Kyle Nelson.
Great, thank you so much, Dr. Orehek, for that really informative presentation. And with that, I'd like to pass it on to Dr. Nelson. Dr. Nelson will be sharing more details about the actual surgical process of DBS.
Good morning, everybody. So Dr. Orehek and myself, we really kind of champion the DBS program at Allina, and have done so now for probably going on about 4 years. I think we've done a great job putting this program together. It's a very comprehensive program, and we'll go through some of that in my slides, as well as Dr. Orehek has gone through that. What I'm going to focus on now is, now that we've determined who's going to be a good candidate or not, now we're going to look at what are some of the steps as far as going forward with DBS surgery. So in moving forward with DBS surgery, you know, we look at a lot of different surgical indications. Again, treating Parkinson's disease, essential tremor, dystonia. We looked for patients that are medically refractory. Again, looking at that on-off sequence. Are you having worsening side effects with your medications? Are they becoming disabling? Are you needing to take your medications just too frequently, and it's just bothersome or burdensome? You're having less on time and more off time. These are all reasons that we would want to proceed forward with potential surgical options. And once people make that determination, you know, it's very challenging, but we are pushing more for earlier surgery because of what we've seen and the success that we've seen with DBS placement. So, you know, where we used to wait, you know, 7-10 years into the disease process, and patients were really in bad shape and not great surgical candidates, now we're starting to do that sooner, you know, sometimes 3 to 5 years into the disease process. Again, there's no set pattern or sequence, but really it's any time that the medications aren't working to the point that we want them to, that's when we start discussing surgical options. This is what we're going to try and break open today. When you talk about brain surgery, we talk about DBS surgery, many people have no idea what that involves. And so we're going to try and crack open this black box of what brain surgery is. It can also be very intimidating and very scary to hear that you may be a candidate for brain surgery, and that going through this you know, may be beneficial to you. One thing about DBS surgery is, you know, I do implantation of the leads awake. Having brain surgery is scary enough, but having it awake when you're able to talk to the surgeon and everyone in the room at the same time, again, it can be very nerve-wracking and very intimidating. We are able to do this, I think, very successfully, and we'll have some previous patients that come on after my talk here to give their perspective. But I think everyone comes into that operating room a little bit nervous, but at the end, you know, is happy that they went through with that. I think this is one of the best slides that I have, because this is really what patients see. You know, you get a terrible diagnosis like Parkinson's disease, and you don't know where to go. You don't know who to talk to. You want to get the best care. You want to get improvement in your symptoms. But you're scared, and when you're looking up the mountain, you know, to see different treatment options, it can be very daunting. And so, what we're here to do in the group that we put together at Allina, you know, we want to try and make this an easy walk for you. We want to help you up this journey and be there every step of the way. And again, it can be very daunting and somewhat scary. So a lot of times people come in with a diagnosis, and you know, that can be scary in and of itself. And a lot of times there's, you know, definitely some medication treatment options and therapy treatment options, which actually patients do respond quite well to. Most of the time it's you know, it's a limited response. It doesn't last forever, but people will have, you know, definite really good responses to those initial treatments. At some point in time, things can change, and you may want to discuss surgical options. And I think once you make that surgery decision, it's tough enough to make that decision, and then you just want to move forward with the treatment plan. And so we try in our program to make sure that we make that as easy as possible. In some other programs, you know, that once you make your surgery decision, that can take 6 months or 8 months or 9 months to actually get through that process. We try and do it in 2 or 3 months. Obviously, with the COVID pandemic, it's been a little bit more challenging, but we're back up to speed now and trying to work through some of that backlog that we have. But once you make that decision, we understand that, we appreciate that. We want to get you through that process as quickly and smoothly as possible. That's getting prioritization with neuropsych testing. It's getting in to see the therapist for your on-off testing. It's having a coordinator that you can rely on and ask questions to help you through. We're here to help. That's that surgical workup. That's going to take some time to get through. We meet on at least a monthly basis, sometimes more often, depending on patients, and discuss their testing, discuss their cases, and then come up with a surgical plan. After we come up with a surgical plan, I generally meet with the patients, kind of give a good overview of what to expect in surgery, and also kind of review of where they've been through their journey to that point. And we discuss, are they a good candidate? Are they not? What are their specific risks or individual risks based on their other medical issues? And then proceed forward with surgery. Once you get through surgery, you're not done yet either, because that's when we go through that programming standpoint. And when we do the programming, patients respond differently to that. And sometimes, as Dr. Orehek discussed, you need to have a little bit more frequent programming sessions. If things aren't working out, that's okay. We can do a lot of things with programming to make that system optimized. So, but that can be, over sometimes up to a 6-month time frame, where we really optimize not only the programming of the DBS system, but also how does that work with your medications, because that's an important part. We want to make sure that DBS system is working in conjunction with your medications, and we're not kind of fighting each other with that. And moving specifically more on to the surgery itself, there's a number of different targets that we use for placement of DBS leads. In Parkinson's disease, mostly it's the what we call STN, or subthalamic nucleus, or the GPI, or globus pallidus. Those are the two most common. When we're looking at targets, this is something we discuss quite a bit at our consensus meetings. Based on your symptoms, how you responded to medications and on-off testing, what your neuropsych testing looked like. Those are all different factors that we take into looking at your target. And we do probably a little bit more GPI than STN, but definitely very comfortable in doing both targets. And again, really, specify that to the individual. For essential tremor, there's really just one target, that's VIM. And so there's really not much discussion there, but that's the most common target that we use for essential tremor. I like to do a DBS surgery, what we call a stage procedure. So it's broken down into 2 parts. And there's a number of different reasons for that, which we'll go through. But basically, the first stage is placement of the electrodes into the brain. This part of the surgery is done awake, as I alluded to earlier. It sounds very scary, but actually, I think we do a really nice job of getting patients through that. And the reason we do that awake is because we actually test those leads in the operating room, and we'll have some of our patients kind of discuss that. But what we can do is, after we get those leads placed, we will connect them up and actually test them in the operating room. You will see how those leads work when we're in the operating room. The reason we do that is really twofold. One, we want to make sure we're in the right spot. We want to make sure you're getting good improvement of your symptoms. And then number 2, we want to look for side effects. If there is any side effects, or you're not getting the results that we want, we can easily remove that lead and move it over a few millimeters one way or the other. And sometimes that can make all the difference in the world. Generally, Dr. Orehek is in the operating room for this part, and she's there to help me get those leads in the correct spot. And I would say our success rate by doing it this way is very, very high. Again, it's a little bit nerve-wracking to have someone operating on your brain, being awake, but this is the reason. And I think part of the success that we have in our program is because we do this so effectively. So during stage 1, this procedure, generally we start this the first case of the day, or first surgery of the day. So you're coming into the hospital pretty early. This part of the surgery is generally about 4 or 5 hours. We generally implant both leads or bilateral leads, so one on the right side, one on the left side. We have you off your Parkinson's medicines for about 24 hours prior to this. Again, so we kind of see you at your worst. And that also gives us a good understanding of how this is going to work, even off your medications. This is done what we call local anesthetic, meaning we numb everything up so you're not in a tremendous amount of pain during this. It's more of the anxiety associated with it. And generally this requires an overnight stay in the hospital. The reason I keep patients overnight after this stage 1 procedure is from a risk of bleeding. So anytime you're inserting something into the brain, you run a risk of bleeding. And that happens, it generally happens in the first 24 hours after surgery. And if it does, I want you to be in a place where we can recognize that and identify that quickly and treat it if necessary. So that's stage 1. Stage 2 is done generally about a week after the stage 1 procedure. So after I place those leads, we've tested them out. I tuck them underneath the scalp and then close everything up real nice. We bring you back about 7 days later for the stage 2. Now this is a much shorter procedure. This generally takes about an hour, hour and a half or so. This is done under general anesthesia, so the patient's completely out. What I do is make that little chest wall incision to place the generator in the chest wall. That can generally go either on the right or the left side, and that's something we discussed during that preoperative appointment. I connect those intracranial leads to what we call extension leads, which are tunneled underneath the skin, and then connect into that generator. That's done as an outpatient, meaning you come into the hospital, we do surgery, and then you generally go home that same day. Now, when we implant this stage 2, your whole system is in place. It's all tested out, but that system is off. And that system will be off until Dr. Orehek turns it on, generally about 3 or 4 weeks after the procedure. The reason we leave it off is not because we want to torture you having this new device in that we've made all these promises for, but we want that brain to scar down around those leads. It makes the programming a lot easier if the brain is scarred down around the leads when we start initial programming. So that's the reasoning behind that. So that's a little bit about the procedure. Again, putting in bilateral leads, that's something that we do through our Allina program that's sometimes not common. Sometimes doctors will, or surgeons will put in one lead at a time. So they'll put in a right-sided lead and then connect it, and then a left-sided lead and then connect it to the generator. And I think that seems to be too much. And for me to put 2 leads in, it takes only about 30 or 45 minutes to do that second lead. And the reason that is because we got everything all set up. We're all ready to go. So we can easily put in that other lead, and really, it doesn't really take much more time. A little bit more about some of the specifics. So I do what's called a frame-based DBS procedure. So this frame over here on the right side of the screen is a frame that is connected to the skull. So you get wheeled into the operating room. We give you a little bit of a hair trim, meaning unfortunately most of or all of your hair needs to come off. We place you into this head ring, and then we do a CT scan in the operating room. And what we do with that CT scan is we merge it with an MRI scan that was done preoperatively, and that gives us the coordinates to where we want to put those leads. And it is very accurate. So we get these coordinates, and then that's when we implant the leads using this frame. Here are some of the pictures from the operating room. So this picture here on the right side of the screen is our intraoperative CT scanner. It's called the O-arm. This has really changed how we do DBS surgery. The way this used to work is we used to have to put patients into a frame. We'd have to bring them upstairs to the CT scanner, do a CT scan, then bring them back to the operating room, merge those MRI scan and the CT scan, and then get surgery started. This saves us about a half an hour to 45 minutes because we don't have to do that. It's very accurate, very easy to do, and it's been working really well for us. As you can see here also, this is what we call that stealth station. That's that computer program or computer module that we use to get those coordinates. So the information from the O-arm goes directly to that stealth station. It spits out those coordinates for me, and then I use this frame to actually implant the leads. You can see here the frame attached to the skull. And again, this is done under local anesthetic. Patients are awake for this and tolerate it very, very well. Unfortunately, during the procedure, your head does have to be attached to the table. So you're not able to move your head and neck very much. You are able to move your arms and legs and kind of reposition yourself to a certain extent. So we try and make it as comfortable as possible. There's many people in the operating room that help us out. There's anesthesia providers, there's nurses, there's scrub techs, there's representatives from the companies that we use for implantation. So everyone's there to kind of help you out. And as many people will say, I think it goes really quite smoothly with the amount of help that we have. We also have a dedicated team that we use at Abbott for these surgeries. So there's really only a few different nurses that I have in the operating room with me, as well as scrub techs. So everyone knows the system and it works just like clockwork. Literally from the second that patient hits the room, everyone knows what their role is, and we do it very efficiently. That's something we worked on a lot over the last couple of years, is to try and get people in and out of the operating rooms as quick as possible. We understand how difficult this can be with you being awake, and we want to appreciate that and get that process done as efficiently and as safely as possible. And that's why we put some of these measures in place to make sure that we have common teams and things that really know what's going on. This picture on the right here, this is after things have been what we call draped out. So this patient is awake. Their face is on the other side of this clear plastic drape here. They're able to talk to the anesthesia person who's up here. They're able to talk to me who's standing back here. This is actually implanting the lead. This is the equipment we use for that. Also within implanting that lead, we generally do what's called microelectrode recording first. So what a microelectrode is, it's a very tiny wire basically that goes into the brain, and we test that wire or test that brain before we implant the lead in first. Sometimes and most of the time we know exactly where we're at and it all makes sense and we put the lead in. Sometimes we do a couple of microelectrode recordings to really kind of identify the different areas of the brain to make sure that we're putting that lead in the right spot. You could just put the lead in and kind of hope for the best, but if it's not, then you actually damage the brain to a certain extent. That lead is a couple of millimeters wide, and so if you put that lead into that GPI or STN too many times, you could actually damage that nucleus, and it makes the treatment less effective. Again, during the procedure, we do intraoperative testing. That's why you're awake. And so after that lead is placed, Dr. Orehek is in there, and she will put you through a number of different physical exam tests to look at rigidity, bradykinesias, tremor, all those different things. We will also play with the different voltages and some of the other measures that we have for the stimulator system to see what kind of works the best. She then takes that information from the operating room and then uses that during the initial programming stages. So again, very helpful to make sure that that lead is in the right spot. It's very easy for me to move a lead in the operating room. Literally takes 10 minutes to do. If we don't place the lead properly and we get you out of the operating room, we have to go through this whole process again. So obviously one of our main goals is to get you in and out of the operating room as quickly and safely as possible, but also make sure that we're doing it right the first time so that we don't have to go back. And again, through our program, we're very, very effective at doing that. We touched a little bit on this in Dr. Orehek's presentation, but DBS is, and I'm sure our patient advocates will share their stories with you, but these are not uncommon improvements that we see. So patients who are in the on state after DBS without any dyskinesias, very high percentages. And this is long lasting. This lasts 5 years, 10 years, 15 years. We've seen this with, in our practices and patients that we've treated. Patients do really well, and they do really well for a long time. So after medications are no longer working, I do think that this is definitely something to think about, something to talk about with your neurologist or a movement disorder neurologist like Dr. Orehek, because I think a lot of people can benefit from this, and that's really important. Of course, with any brain surgery, we have to talk about complications. Nobody likes to talk about complications, but I think it's important that everyone be on the same page going into this. This is not a perfect procedure. There's problems that can happen, but it's very manageable. Luckily, in our practice, we have very few complications, but they can be catastrophic when they happen. I would say the biggest complication or most catastrophic is hemorrhages. Again, probably happens, I would say less than 1% overall, but when they happen, they can be very debilitating. And so we do everything we can to try and prevent that, including as we're planning those trajectories for the leads, trying to navigate around the major blood vessels, sometimes changing our trajectory to implant it into a place that's going to be safer from a blood vessel standpoint. Those are all things that we do to try and prevent that. But that, again, that is the reason why I keep you overnight in the hospital, is because if that were to happen, generally happens in the first day. And I want you to be in a place where we can identify that quickly, diagnose it, and also treat it if necessary. The other big complication that we see, again, not in our practice as much, but overall, is infection. If anytime you cut the skin, you're in the risk of infection. Anytime you cut the skin, you put a foreign body in something that doesn't belong to you. If that thing gets infected, a lot of times that whole system needs to come out. And so going through all this work to have all that hardware removed, is really tough to do, especially putting someone through an open awake brain surgery to do it. But a lot of times we can't clear the infection unless we take the hardware out. And lastly, some problems with, lead fracture or some issue with the generator. We just don't really see that. Of the 3 companies that currently have DBS systems on the market, all are very reliable. They have very good equipment. And we just don't see some of these lead fractures and issues that we did in the past. And so I think no matter which company we elect to go with on any individual case, I think you're getting a good quality product. And again, we just don't see that as much. Again, a little bit more about our Abbott program. We're a comprehensive program, meaning that we have all of the components that we need. We have physical therapists, we have on-off testing, we have neuropsych testing, we have a movement disorder neurologist, Dr. Orehek, we have a neurosurgeon that does a lot of functional neurosurgery, such as myself. So we have a true comprehensive program. Recently, over the last year or so, we've had Kelly, who's our nurse coordinator, again, really effective and helpful to keep patients kind of on track. Someone that you can go to, even if you're going to different appointments, that you can ask, hey, am I supposed to take my medications? What dose? When am I supposed to be off of them? A really great resource that we have to help. And of course, Anushka, who's really key in setting up things like this to kind of get the word out and have people understand, in a comfortable way what DBS surgery is all about. We have an efficient process. Again, our goal is to get people through on-off testing and neuropsych testing as quickly as possible. And we want to do a good job, but we also understand that, waiting 6 months or 9 months to have, once you've made the determination to have surgery, can be really challenging. We do bilateral lead placements. I think that, again, from an efficiency standpoint, is probably the most efficient thing to do, because once you're on the table, you want to get everything taken care of at that same time. You don't want to have to come back a month later and have your second lead placed. We have multiple locations where we do clinic. And Dr. Orehek and myself are, we don't go too far outside the Twin Cities, but definitely within the Twin Cities have many locations where we see patients and can do programming or discussions about DBS procedures. We have at least a monthly multidisciplinary consensus conference. Again, that includes all of us, myself, Dr. Orehek, the physical therapists that do the on-off testing, the neuropsychologists that are there. We do, we all get together and talk about each of the patients and determine if they're a good candidate for surgery. And then, again, what location would be best to implant their leads. We have excellent results. Hopefully our patients will share some of their stories, but we do a really good job, low complications, and really help a lot of people. And again, we do community education events such as this. You know, we try and get the word out to try and make this not so scary, to try and make this not so intimidating. I think that's really helpful for patients as they're going through this process to understand, you know, what is involved with DBS surgery and who can be benefited from this the most. A lot of times patients come to us from other neurologists, and so we're happy to work with those other neurologists as well. You know, just because you get into our program doesn't mean that we need to take over and you can't ever see your neurologist. A lot of times you've been with that provider for many years. You know, they've given you tough diagnoses and tried to help you through that. And I think it's important for patients to maintain some of those relationships. Sometimes even from a convenience standpoint, you know, if you live 100 miles away, driving down here to see us, maybe it doesn't always make sense. Maybe seeing your local neurologist can sometimes be just as beneficial. So we do see other patients from other doctors, and we're happy to work with them through the process. Many of those outside providers don't have some of the resources we do for things like DBS surgery. And so we utilize our program to help with the workup and discussion in regards to some of those procedures, but also get you back to those individual providers once things have been implanted and programmed, and you're kind of to a new steady state. So again, we have a lot of relationships around the state that we utilize for referring providers for our program. This is, I think, kind of sums everything up. You know, DBS surgery, it's very safe, it's very effective, and it's definitely life-altering. We're going to have a couple of patients that are going to share a little bit about their process and some of the improvements they've had, but I think they're going to echo a lot of what we've shared here with you today. Again, this is a big deal. You know, having brain surgery is not something to take lightly. Hopefully what we've done is answered some questions and kind of made this a little bit easier to understand and not so intimidating. And when you get to the top of that mountain after you've recovered and had your DBS system, you know, a lot of times people say, you've given me my life back. Someplace that I've never thought we'd get to again after I was diagnosed. And so I think that's something that's really important, something to keep in mind, that even though this is a tough decision, even though this is a lot of work to get through, at the end, patients are very happy and very satisfied with the results that we get. Again, a number of different people on our team, myself, Dr. Orehek, Kelly, Anushka, everyone is here to help you and get you through the process as best we can. You have all been in contact with Anushka as she coordinated this event for us. You have her information. We also have an Allina DBS website that you can go to. It does echo a little bit of some of the information, not nearly as thorough as what we've presented here today, but also has some different resources there for you. If you have any further questions or want to get in touch with us, Anushka is a great resource. She can work on setting up some of those appointments or getting you in touch with the people that you need to. So feel free to email her, call her. And again, we'd be happy to even have just a conversation about where you're at in your disease process. Are you a good candidate for DBS or not? These are very simple conversations for us to have, and sometimes really provide patients, the comfort that they need to proceed forward with something, regardless of who their neurologist is. Having some of those conversations, I think, are very important. With that, that's all I have. Hopefully this helps clarify some of the procedure questions that have come up. I think now we're going to have our two patient advocates. It might be best, I think, if Stu starts first. Stu just recently went through the procedure. He's about 2 months out, give or take now. And I think just coming off the surgery talk, I think it would be good for him to kind of give his perspective, just getting through surgery and now getting through initial programming. And then maybe we'll turn it over to Jim to give us a little bit more insight on the long-term effects of DBS and how it's changed his life.
Good morning. Join audio, start my video. One. Start. Ah, there I am. Okay, you can hear me. Good, good. Well, thank you very much for the opportunity to talk. My name is Stu Bauman. This is my wife, Linda Kelly, right next to me. Very quickly, as far as diagnosis goes, we've heard a lot of talk about that. I was diagnosed about 8 years ago, and I did not know that I had Parkinson's until that point. But there are some precursors, like losing your sense of smell, that happened to me 12 years before diagnosis. So when we actually get diagnosed is often when we've been suffering or experiencing the disease for a while. So it was about 4 years ago that I decided I wanted to pursue deep brain stimulation surgery, but I was not a likely candidate at that time. I went through the whole testing program, and they said, well, you're not quite to the point where it's going to do much for you. So I put that on hold, and then my life got pretty busy for the next couple of years, and it was not until November of last year that Linda and I decided now was a good time. The window was open, and we planned my surgeries for March of this year. Well, that didn't work out very well because of COVID-19. So we had to cancel surgeries. I was lucky though, by the end of April, I inquired about the surgeries, and we were able to schedule for early June. So I had an MRI on the 25th of April and had surgeries on the 3rd of June and again on the 10th of June. And they went just like Dr. Nelson talked about. I had to be at the hospital at 5:30, and it's just the hospital pre-op. They've got all sorts of surgeries going in there, so that you're there plenty early so that everybody has time to get you squared away. So you check in, and it takes about a half an hour before they give you a room, and then you're dedicated in a room with a nurse, and you get a gown, and you do all that, and they tap an IV in the back of your hand, and they get you all ready. And then usually about 7, the anesthesiologist will come in and talk to you. And Dr. Nelson will come in with the team, and they'll talk to you for a few minutes. And then it's usually about 7:20. By 7:30, they wheel you into the operating room, and it's just right around the corner. And I was really amazed because it's a dedicated operating room, of course, but they've got that CT scanner right there in the room, which makes it very easy, that Dr. Nelson referred to. So if you remember the picture of the patient there, I'm going to show you what it looks like when they get me hooked up here. This is a picture of me in what I call the halo. They call the stereotaxis frame. That's what it looks like. And if you see the dimples here on my forehead, those last about 2 weeks before the soreness goes away. And that's the biggest thing that I noticed was it was where the frame was attached, and it does hold you there. So I was in the frame for about 4.5 hours. So you can put it back there. Thank you. Here. Let's see. So, oh yeah, one thing before they put me in the halo, I got a haircut. I got a free. Well, it was not exactly free. It was a barbershop haircut at surgeon prices. So they shaved my head though, and so when I was in the once I was settled in my bed and the plastic sheeting was over my head, the only thing I had was a view of a wall, similar to what you can see in the background now, and there's a clock above the door of the wall there, which is the only thing that I had reference to, and I was thankful for that. So I did not see a clock in the picture of the operating room, however. So let's see, got in there. So then it was time to start drilling, and I didn't see the drill beforehand, but Dr. Nelson described it as similar to a dentist drill, and he kind of clicked the trigger on it, went zzz, very much like a dentist drill. But when you start drilling on the head, there it feels like a dentist drilling into your jawbone, but it's your skull and it's much more pronounced. So about 20 seconds into the first hole of being drilled by Dr. Nelson, I could hear little bits and pieces being vacuumed up as the drill was going. And then all of a sudden I heard a clunk and I felt something on the top of my head. And then there was silence in the operating room. And I did not know what had happened, but I didn't hear anybody say, uh-oh. So I assumed everything was okay. And Dr. Nelson said, yes, everything's okay. We just broke the bit. That happens. We'll go on. So they did. And I think there was a little bit of a chuckle for that one. So let's see. Then that stereotaxis frame definitely holds your head in place. My head didn't move for very much until about the 3-hour point. I kind of shifted my body, and Dr. Nelson cautioned me to be careful. So, and it takes about 90 seconds to drill each hole, which seems like an eternity when you're locked in and everything's going. But it was at this point in the operation that I realized that I was really committed to this. Because I had decided to do this 4 years ago, I didn't think very much about it because I had gone through the mental process of research and asking questions and deciding that that's what I wanted to do. And then in the last year, as I got ready to go in, I didn't give it any extra thought. And I questioned myself and said, shouldn't I be a little bit worried about this? And when they're drilling holes in my head, I finally realized, I committed to it at that point, but I had no apprehension about it in the immediate lead up to the surgery. So I finally figured out that I just processed all that years ago and didn't go through it again. So let's see. The plastic sheet is kind of an interesting thing because it wraps around your head, and everything up here is sterile and everything down here is not. But I can't do anything about it, and I have a very narrow window of view. So that was an interesting part of the surgery. So that started all around 7:30, 7:45, and about a little after 10 o'clock was when Dr. Orehek came in and they started running the testing, and that was kind of interesting. That's why I needed to be awake, so that they could they can turn the stimulation on, and they're asking me to do finger taps and stabilization. You can see a little bit of tremor right now, that sort of thing while I'm in the bed. And Dr. Orehek will be varying the intensity of the stim at the time and checking the reaction of my body. So that was pretty interesting. So, and then I got to spend the night in the hospital when they were all done and sewed me up. And they used that CAT scan a couple of times during the process, in and out, and it was very nice to have it right there. So about noon, I got to go to my room. Now, because of COVID-19, the hospital was not very busy. So I had a private room and I had a private nurse, so to speak, although she had 2 other patients. But they were very attentive, and about every 4 hours they came in and they would do a neuro eval to make sure that the finger taps were still working and the toe taps and the pushing and pulling of the arms and legs. So let's see. So and then the next morning they made sure that PT and OT came by, a physical therapist and an occupational therapist came by to assess me very quickly before discharge. So that was, and you get up and you get to walk around the unit several times the day of, and at least one time the morning that you're discharged. So you get a tour, a walking tour. They also don't want you to get out of bed for anything. You have to call the nurse, even if you just want to get out of bed and go to the bathroom, which I felt perfectly capable of doing. But they say, no, we do not want you to fall. Well, that all makes sense. So second surgery, a week later, the pre-op was about the same, 5:30 at the hospital. And then once they put the gas mask on me and I went under, the next thing I knew, I was in post-op. And when I cleared enough, I met my wife again, and home we went. So then just 2 days ago on Wednesday, I went to Dr. Orehek about 2 or 3 weeks after that second surgery and got the initial programming of the stim. And then lived with it for about a month, trying to figure out what it helped, what it did not, where we stood on medication. And then I went back for the second programming just 2 days ago. So I'm still in the process of learning, figuring out medication and stimulation. And now I've got the ability to vary the amplitude a little bit, both left side and right side. So that's where I am now, just working and trying to give the doctor the best feedback I can so that the next programming can be even finer tuned. So with that, I will hand it over to Anushka and our next patient. Thank you.
Thank you so much, Stu, for sharing your perspective and your process. I think that was really illuminating. Now with that, I'd like to turn it over to Jim, who's been living with DBS for a few years now, to share kind of a long-term perspective of how DBS has impacted his life.
Good morning. Anushka, can you hear me?
Yeah, we got you, Jim.
All right, very good. My name is Jim Prittman. I'm a retired dentist, and I was diagnosed with, I'm 63 years old, and I was diagnosed with Parkinson's when I was about 48. And the first 8, maybe 9 years of my disease process, medication handled pretty well. I was taking Cinemet and taking more and more Cinemet, but I was doing pretty well until one day it almost seemed like it was the switch was turned off. I wasn't doing very well anymore. And my big problems were tremor, dyskinesia, muscle stiffness, and lack of balance. And so my neurologist said it's time for deep brain stimulation. So he referred me to Dr. Orehek, and I was immediately kind of taken in by her. And she married a guy from the Iron Range, so she can't be all bad. And because I'm from northern Minnesota, and I was impressed by her ability to listen and her caring. Actually, she took the time to really listen to me and talk about what I needed to do. And my process through the surgical procedure was pretty much the same. It was really adequately described and accurately described by Dr. Orehek and by Dr. Nelson. And Stu gave a very good account of what happens in the operating room. But I'm going to share one story with you. And I don't even know if I've ever told Kyle this, but as a dentist practicing in northern Minnesota, I had the opportunity to do a lot of dental surgeries in the hospital. So I kind of know my way around an operating room a little bit. I probably did 2 surgeries a week for the better part of 25 years. Not a lot of specialists up here. You learn to do a lot of stuff yourself. And so I kind of get the interaction between doctors and nurses in the OR. And the surgical procedure that Stu described was very similar to mine. But Dr. Nelson put the first implant in and went to do the left side implant. And I had some sort of an anatomical anomaly that made it difficult to place the second implant. So it took him a little time to do. And I was awake and observing the whole thing, and the whole team worked together so well. Dr. Nelson didn't lose his cool. It was a little bump in the road, and he handled it beautifully. And I thought, how you respond to a little crisis is very important as far as assessing, if you're really going to trust a surgeon. And I think Stu said when the burr broke, and when they drilled the holes through my skull, I thought it was the same thing, that it was like a dental drill. And I suppose it's payback because I did that to people for many years. But when the burr broke in Stu's case, again, no panic, just, go on and do the best you can. And I went through the whole process of turning it on. I feel like the month in between the time where they placed the battery and the time they turned it on was a month of hell. My symptoms were really bad. I couldn't move. And it was just anxiously waiting to get the stupid thing turned on. And there are good reasons for that, predominantly because of healing. Like I said, my symptoms that caused me to do the DBS were tremor, dyskinesia. I was a real mover and a shaker. muscle stiffness. I couldn't get in and out of bed myself, and lack of balance and poor gait. The DBS absolutely stopped my tremors, absolutely stopped my dyskinesias. I would say 99%. I'm a lot looser now. My muscles are a lot less stiff. In fact, I remember it was a Friday afternoon that Dr. Orehek turned on my machine, and the first thing I did was bent down and took my shoes and socks off and put them back on again, because I couldn't do that by myself before the DBS unit was turned on, and I immediately felt looser. I mean, the effect was instantaneous, and so I felt like I had to try to put my socks off and on. And it's the little things that get you sometimes, and that made a big difference. Now, Kyle said it very accurately, and he stole my thunder. DBS has given me my life back. I'm able to do a lot of things. I lecture extensively and travel extensively to lecture on dental topics. Although with COVID-19, I haven't traveled since March, but I am doing a lot of Zoom meetings. In fact, I did one last Sunday for 5 hours and had 220 doctors. So I'm still operating, and still being able to work and still doing what my passion is. And I attribute that directly to DBS surgery. And I will always be grateful to Dr. Nelson and Dr. Orehek for how they handled this process. And one more thing, I'll shut up here in just a minute. It's brain surgery. There are issues. And I felt that the informed consent that I was given by both Dr. Orehek and Dr. Nelson were first rate. I understood the risks and complications of surgery, the risk of doing surgery, the risk of not doing surgery. And so I feel that I was well informed regarding surgical risks, and I think that's really important. It leads to trust of your doctor, and healthcare is all about trust. And if you can trust your surgical team and your doctor team, you will do a lot better than if you don't trust them. And I have found every reason to trust Dr. Orehek and Dr. Nelson, and I will forever be grateful for what they've done for me. So if anyone has any questions, I'll be happy to answer them.
Jim, thank you so much for sharing your perspective. And I think between your story about living with DBS long-term and Stu's, we've gotten a really comprehensive view of how it's affected both of your lives. And
Anushka, I want to say a couple more things that I kind of forgot.
Mm-hmm.
It's been 2 years since March. It was 2 years last March where my machine got turned on. And my tremors and dyskinesias have stayed really close to zero. My muscle stiffness has really improved. My gait has not improved, and that is one of the disappointing things. But apparently the DBS, that's more of a physical therapy issue. My balance is a bit spotty. It's better because I have less muscle stiffness, but I still have balance issues. And I don't think DBS manages those symptoms quite as well as it does the tremor and dyskinesias and muscle stiffness. But medication somewhat controls, makes my gait better when I get dopamine in my system and helps me with my balance. But I feel so good I forget to take my meds all the time. I saw Dr. Orehek this week in a teleconference, and I got to be honest, I'm a poor patient because I'm not taking my meds like I used to. I'm down to about half to a third of the dopamine that I used to take. I probably take 3 Cinemeds a day. So I'm making a concerted effort to try to be a better patient and take it at regular intervals to see if that helps me with my issues. But tremors and dyskinesias are gone. I remember a week after my machine got turned on, I was at a social event, and a casual acquaintance of mine came up to me and said, "Gosh, you're so still." And that kind of says it all. So.
Absolutely. Thank you for providing that perspective for us on the different things that you've seen happen and be affected in your life. And With that, I want to encourage everybody, if you have questions for any of our speakers, please feel free to type them in the chat. I have received a couple of questions first that I want to hand over to you. One of them, one of the questions was, what are the costs associated with DBS? Like, is it covered with insurance?
Oh, can I answer that? My insurance company denied my surgery at first. And so I got a bill from Allina for $140,000, which is never a good day. But I wrote some letters to the insurance company, and you know, my network didn't include anybody in the Twin Cities area. I would have had to go to Chicago. And, you know, that would have just been impossible with all the travel necessary and all the workup necessary. So a couple of letters, and they decided to cover it. And I think my share, and I've got a large deductible policy, my share was about $15,000 or $20,000. And I looked at the bill, and I could have fought for a little bit more, but I decided not to. You know, when it goes down from 140 down to 20, you know, I'm pretty happy. So there will be significant, depending on your insurance coverage, there'll be significant out-of-pocket costs, but for the most part, with a little work, my insurance covered it.
Yeah, I can touch on that a little bit too. So most of the time, most insurance companies will cover DBS procedures for Parkinson's and essential tremor. And so I think Jim's situation is a little bit unique, but oftentimes I can write letters, Dr. Ray can write letters, or the patients can be their own advocate. And those,
yeah, I didn't get to that stage where I needed you guys. I didn't get to that stage where I needed you guys, Kyle. You know,
yeah.
that would have been the next step.
Yeah, and I do that from time to time for a lot of different patients. And so I think, you know, it's obviously very individualized based on your individual insurance plan.
Yeah, given my coverage plan, I was pretty happy with, given the coverage that I pay for, I was pretty happy with the overall coverage when it was all said and done.
Yeah, and I think Jim's right. I mean, it's probably about $140,000 total from the hospitalization and OR costs and equipment costs and things like that. But most insurance companies cover it quite nicely, and we have a lot of things in our office that we do to help patients out if need be, to allow insurance companies to cover those. The on-off testing, neuropsych testing we're doing is definitely very important and definitely needed most of the time to get pre-approvals. My office before surgery will get pre-approvals with the insurance companies prior to any surgery that we do, to make sure that everyone knows where they're at as far as in-network, out-of-network, and what their costs would be associated with that. So.
Okay, great, thank you. And my next question is directly for Dr. Nelson. Somebody wanted to know how many surgeries Dr. Nelson has done for DBS, and what is the success rate?
That's a tough question. I've been doing DBS surgery, including in my training now, for about 14 years total. I've been doing DBS surgery since I've come to the Twin Cities and started practicing 7 years now. In our program, we do right around 30 procedures, 25 to 30 procedures a year, which I do all the implantation for. And those are going to be bilateral systems, meaning that we're placing, you know, one lead on each side for each of those patients. So those are complete systems that we do. So this year is much different. Obviously with COVID, we've done, I think less than 10, I know this year so far. But most years we're doing, you know, almost one a week from a DBS standpoint. And I do a lot of other procedures too, very similar to DBS for epilepsy and things of that nature. And then our success rate, I think there's a question of how you manage or how you define success. I define success personally as Stu and Jim. You know, I think those are not isolated patients. Those aren't the only two patients we had that we help. We help a lot of patients, and I, you know, when they give their stories and how they got to this and the success that they've had with DBS surgery, I mean, that really makes me happy. That's why I do this. And so I think that's success. You know, we have really successful program. Dr. Orehek is one of the best programmers that I've ever worked with, to be honest. She makes me, I think, look really good because I can put leads wherever in the brain and she'll make them work. because of how good she is at programming. So I think, again, this is a team sport here. We really rely on each other for a lot, both Dr. Orehek and myself, to really have the success that we do. Again, knock on wood, our complication rate is very low. It's as low as anywhere in the country. We do have complications. Thankfully, they're far and few between. But with any brain surgery, you're going to run into risks. I'm going to try and mitigate those risks for any of my patients as best I can. But the things can and do happen. But I think overall, we have a very successful program. We have very happy patients that again, this is really life-changing for them.
Thank you, Dr. Nelson. And my next question, I think, is for Dr. Nelson and Dr. Orehek. And I think this is, something that a lot of people can relate to. The person who asked the question said, I have been told that the recovery period, meaning no work or expected high mental stress, is 6 to 8 months. I work full-time and can't imagine taking that length of time off. What is the recovery period to return to work?
I think that's a very long time. I wouldn't recommend that we would have someone recovering for 6 to 8 months. It's probably more on the line of about a month or so, probably 4 to 6 weeks. Maybe Stu or Jim can chime in and say what their recovery was like. But most of the time, by the time patients come for their second stage, actually, they're pretty well healed up after their initial lead placement. I generally keep people off of work until they've done some of the programming because they get the benefit of the DBS and they're really fully recovered at that point. And that's generally, you have a pretty good handle on that on 4 to 6 weeks. But maybe Jim or Stu, if you could chime in and say what your recovery was like.
I traveled to San Francisco and did a seminar 6 weeks after the battery was implanted. So that was like 2 weeks after it was turned on. And I had no problem with the travel or with any of the issues. And so, I would say from the time the battery goes in, the recovery starts, and 6 weeks after that, you'll be ready to go back to work. Or at least I was.
Yeah, I remember having that conversation with Jim, like, can I travel at this time? And it was like, well, let's try to be a little cautious about it. But I think if you're planning on, depending on your work level and how busy you are at work, and those things are all considerations. From a pain standpoint, it's minimal. It's not like a hip or a knee where you're laid up for more time. So it's more dependent on your meds and how the surgery impacts the effects of your meds. But I had a patient go back part-time even before we turned the battery on, and then started like incrementally increasing how much she was working. So the 6 month is probably more like when we expect it to be finer tuned, but certainly before that, people can return to more normal function. I don't know, Stu, if you have a comment. I know you're not working, but.
I would agree with that. I'm 69 years old and I'm retired, and I was an airline pilot. No, I'm retired because I'm too old to continue flying as a pilot, and of course I could not have done that going back until I requested waivers, and I don't think that that's waiverable DBS for airline flying. But most jobs, I would say 6 to 8 weeks is probably very good to be able to go back and function in a normal way. Yes.
Great, thank you for sharing that. And I have another question that's come through specifically for Jim. The person has asked, I'm wondering what type of gait issue Jim had or has that didn't respond to DBS, because gait is a big problem for me too. And how much Cinemet was he on pre-DBS? So like how much have your medications kind of reduced?
Okay, pre-DBS I took about 6 a day. And now I'm down to about 3 a day when I remember to take them. I mean, I could go a day without taking meds and probably function pretty well. My gait, I tend to speed up and I tend to fall forward. And so I'm constantly reshuffling to gain my balance. And what I found is when I practice my gait, it gets better. It just takes discipline to practice it. And I happen to use walking sticks plus a metronome on my phone to try to keep my pace constant, and the sticks to help keep me upright. And walking through airports, I travel quite a lot. I carry my sticks with me. I've never had to use them in an airport, but what I found was putting a backpack on with some stuff in the backpack so there's a little weight helps keep me upright. And so, I guess my gait and how I walk is the most disappointing aspect of my disease right now. But I can maybe help that a little bit by doing physical therapy and practicing a little bit. And I've been a little lax with that, I have to admit. So it's partially self-imposed. But the shuffling, small steps, leaning forward, tending to speed up, all the things that are associated with the Parkinson gait, I've got.
Yeah, just to piggyback on that, like the shuffling part of the gait difficulties often does respond pretty well, but there's gait freezing that can sometimes even get worse after DBS. And then that propelling that Jim's describing, where you kind of get running and go forward, that can sometimes become more of an issue after DBS than it was before DBS. But we can try to make adjustments in programming to work around that. So some things improve, but yeah, there's definitely some gait things that can become more of an issue afterwards.
Absolutely. And I've had I've had 2 questions come through for Dr. Orehek. One of the questions, the person says, I'm 61, I have a slight decline over time, but overall, I'm doing pretty well. I'm in charge of my young son, and I'm terrified that something could go wrong and compromise my ability to take care of him or his college education. Would it be recommended to wait on DBS for 4 years until he is out of college?
So that's a good question and a tough question, but those are all things that we talk about and consider when we're thinking about DBS. Like, how well are you doing now? How well are you functioning? And it sounds like you've had some progression, but there's likely some changes in medication and other interventions that you could make over time. I don't know if it will get you to the 4 years, but it would likely be manageable if you wanted to wait, because I think those considerations about your responsibilities and other things, because even though there is such a low risk, that 1% of a bleed, if it does happen to you, it could be potentially devastating. So I think those things, taking into account how you're doing now and do we think you can continue to function, I would imagine, it sounds like, and I'd have to see you and talk to you one-on-one, but I would imagine in 4 years you would still be a candidate. So I don't think you would like go and miss a window. So it certainly can be an option to wait.
Thank you. And I have another question. Dr. Orehek, Dr. Nelson, and Stu and Jim all mentioned a kind of 6 to 8 week period of recovery. And someone has asked, what does that 6 to 8 week period look like? I have teens who will be home with me doing distance learning. Will I be able to help them from the couch, or will I be sleepy and out of it?
I don't remember being particularly sleepy. I just remember having trouble moving, but sitting still was not a problem for me, sitting and doing something. It just, whatever symptoms you have are not quite resolved until the machine gets turned on. And a lot of it's just anticipation. You want to get going on this thing, but you got to wait. And so I don't think the recovery time would affect what you're talking about right now.
Thank you for chiming in. And Stu is going to chime in as well with his perspective.
Yes, I think that as far as not sleepy, it's just you're fully not functional. You're not at a level that you will be when everything gets programmed, and you may not. And for me, I was not at the level that I was before surgery, but I'm constantly tweaking my medication and trying to find where I am in the program right now, what best suits me. So I'm able to do things, but just like some days are better than others, I can't do everything on any given day, but I think I could accomplish the essential tasks, no problem. There are days that, yeah, I have to take a nap and I've lost an afternoon, but I can't do anything about those. So, but I really do believe you could do normal things, and schooling your kids, I think would be okay, yes.
Wonderful. This person just said, thank you all so much for sharing your perspective on that question. I don't have any other questions in the chat box. So I do want to say, if any of you, someone has just submitted another question for Dr. Orehek and Dr. Nelson. She asked, do you need to program differently if the person is very active? For example, if they're really active in sports or exercise, can a patient self-program at some point, or is tweaking of the DBS not really needed after the programming is completed?
Yeah, so good question. So I generally would program based on your symptoms and not necessarily, like, the goal would be to get anybody after DBS back to an active lifestyle. So I don't program differently depending on what activities or sports or things that you enjoy. We would recommend against contact sports just from any sort of trauma to the neck and injury and potential injury. But otherwise, like, maintaining active lifestyle, that's the goal with all my patients. As far as giving people some independent control, usually I wait after a few programming sessions to do that and kind of gauge where someone's at with their comfort level, because everybody has a little bit of a different approach and comfort level with making adjustments. Like, some people are very hands-off and other people want to jump in, and some people might have a tendency to change too much. So we talk about that. And there are usually, you can get to a stage where you should not have to make a lot of changes throughout a day or throughout between appointments. So the goal is to try to find like an optimal setting and then not have to make a lot of your own adjustments. But there's things like, I'll see you and I can give you option 1, option 2. You can try option 1 for a while and then have the option to switch back to option 2 if that was working better. So I like to give people a little bit of options in between appointments to gauge settings.
Great, thank you. I have another question that just came through. Someone wanted to know about driving, like after or during the process. Is that affected if you have DBS?
Dr. Nelson, do you give restrictions on driving from a surgery standpoint?
Yeah, generally we don't. I don't promote driving until you've kind of healed up. And so from a sequence standpoint, generally you have that first stage surgery where we implant the leads. Obviously no driving probably between that and the second stage a week later. And then I generally see you about 2 weeks out from that second stage for staple removal. And at that time, we can talk about kind of getting back to some normal activities, assuming on how you're doing and things. Most people by that point are kind of back to their pre-op setting, or kind of their pre-op status. And so if they're driving before surgery, they can drive after surgery. So it's kind of individualized, but generally not a huge burden from that standpoint.
Great, thank you.
I can say from my perspective, I hold a commercial driver's license for a school bus. I'm not using it currently except for very, very part-time, but professionally I would not drive a school bus, probably not even today, and it's been almost 2 months for me since surgery. The first month, 3 weeks to 4 weeks is after the final surgery is when I felt like I could be okay driving my own personal vehicle. Definitely not exercising the privileges of a commercial driver. No, I would not even do that today.
Thanks for sharing your perspective. I have a question. Are there any contraindications between like getting DBS and having diabetes? Because this individual has diabetes.
Again, we look kind of at an individual standpoint at everyone's health history and the different medical issues that they have. I would say diabetes in and of itself is not contraindicated for DBS. It may increase your risk, specifically of infection, a little bit higher than others. If your diabetes is under good control, you have almost no increased risk of that. So again, that's something we would discuss at your preoperative appointment, talk about, is your diabetes under control and what kind of medications do you take and things of that nature. So that in and of itself does not preclude you from undergoing surgery. And almost everybody, when they get into their 60s and 70s, has some sort of medical issue, hypertension, hypercholesteremia, diabetes, something like that, that we have to work through. And so it's not uncommon for people to have medical issues that we need to discuss. And again, it doesn't preclude you, but sometimes may increase your risk slightly or something like that. But we would discuss all of that on an individual basis.
Great, thank you. So I want to let you all know that if you have any questions that come up after this presentation, please feel free to email me. My email address was shared on Dr. Nelson's slide, and you should all also have my email address because you contacted me to register. I'm happy to pass your questions on to Dr. Orehek and Nelson and help get you the answers that you need. And I believe that's all the questions I have in the chat box. So does anyone else have anything they would like to say before we wrap up today?
No,
I would
just-
like just to thank Stu and
Yeah.
Jim for sharing their story. I think they did a really nice job kind of reiterating what we've talked about and validating, I think, what our program has to offer for patients. And I just can't thank them enough for helping share their story and provide some insight to potential patients that may be thinking about DBS surgery in the future.
I agree. I think they did a fantastic job of sharing their perspective. So I got a question about sharing the slides, and I want to let all of you know that we did record this presentation and we will be posting it online on the Noran Clinic website. I will email all of you when we have that recording live on the website so that you can refer back to this presentation and the slides in case you'd like to share this with other people in your family or in your network that would like to know more about the process. And before we leave today, I would like to, I'd like to redirect your attention to the poll at the bottom of the page. We would love to know more about where you're located and how you heard about this event. So just before you click off today, please, if you can, check the poll and reply. We'd be happy to hear from you. So thank you to Jim and Stu. Thank you to Dr. Orehek and Dr. Nelson for taking the time to share their expertise with us today. And thank you to all of you for being here with us this morning. And please get in touch with us if you have any further questions moving forward. I hope you all have a wonderful rest of your day.
Thanks,
My
Anushka.
pleasure.
Thanks, Dr. Nelson. Thanks, Dr. Orehek.
Thanks, Stu. Thanks,
Jim.
Jim.
Hope to meet
All
you
right.
soon.
Bye. Take care.
Bye-bye.
Bye.
Let's see.